Okay, we are live now.
Okay, good morning, everyone. Today we are going to look into rather complicated way of looking at evidence because today we are looking into sort of a review of reviews, if you will, or the other day Dr. Anand was telling that the better name for might be also network reviews. So what we are going to do today is that there are different parts to management of cerebral palsy, from starting from reducing spasticity or contractures up to surgeries and pharmacological management, right? So what they have done here is they have collected numerous systematic reviews on each of it, right? Let's say, for example, a systematic review on contracture prevention, a systematic review on task-oriented training, uh, for rhizotomies, for single event multi-level surgery. So they have collected everything and they try to answer questions which are pertinent to cerebral palsy in one go. The first state of evidence was published in 2013, and what we are going to see today is an update on that, right? So we are going to see what is mm, what is the state of evidence about physiotherapy, about cerebral palsy, right? I'll just share the. Can you make me a host,
Uh,
Prakash?
just a second. Yes.
So this is the article which we are going to talk more about, right? It's called a state of evidence. The traffic light basically means that there are three things they have used, the three colors they have used, your red, amber, and green. Basically, what green means is that you can use it, right? Because the evidence is okay or good for mm, uh, on date, right? On date, it is okay. The evidence is okay. And red means the evidence is so poor, probably don't do it. And amber means that try it out depending upon your patient and a lot of factors into consideration. Try it out. It cannot be generally everybody can be tried out and things like that. And also, I want to give a slight reminder, uh, which Novak and co-workers have done. I'll just add that also. If you scroll on your article, if you have already read that, you should have seen that also. Uh, it's sorry, I'll just you can see that there is a thing called as guide to interpretation. Uh, are you? I'm hoping you can see it, right?
Yes. Yes.
Uh, right. So you need to see these things. There are two issues in this you want to remember. They are clearly stating that this is the current evidence at this point of time, right? They are not telling that you don't use that and this. This is not their personal opinion. This is what it is there. And also, the other thing we want to remember is, unlike a lot of other uh, systematic reviews, they have not just used or taken RCT. Some of them also have taken observational studies. So that is a thing you need to remember, right? And also, one of the things which we commonly see is that people getting defensive that no, this works, this works, this works. That is not the idea of review. The idea is to tell us what is the evidence currently available. If you are wanting to change, change. Otherwise, I don't know uh, how to say how you all want to look into it. It's up to you. But this is the way to
Uh,
look at it. Prakash, do you want to add more?
In your screen, okay, there is some.
Yeah.
Okay, fine. Uh, so basically, every time we are asking question, this treatment is effective, that treatment is effective, and so on. This systematic review answers most of those questions related to cerebral palsy, right? So what we can do is you can start your questions on related to interventions for cerebral palsy, and we can look into this review for looking for answers, specific answers to this evidence. This is how we have been saying evidence should be looked into, that is the body of evidence, not one single article, right? So can you all start asking any questions related to cerebral palsy, but only on intervention related questions?
Uh, if you're not on the, if you're not speaking, you need to mute your mic. Selva, I think you need to mute your mic.
Sir,
Manoj, you need to mute your mic so that we have lesser disturbance when we are talking.
sir, actually, what should we concentrate or consider before choosing an intervention?
Prakash?
Evidence of effectiveness and feasibility.
Right. I think that's the simplest answer. I think not just the evidence, you need to look into the feasibility of it also. Because I see a lot of people have this idea that we will have nanotechnology, robotics, and VR and things like that, which I find it ridiculously nonsensical, because the COVID has proved to us that I don't want to see that or tell as though some states are poor or worse, but if you see some states, they don't have ventilators, right? They don't have ventilators. They are so afraid to get the migrants into their home, into their state, because they just don't have ventilators in large hospitals, not in where Revati is working, not that 50-bedded hospital. They don't have large hospitals, don't have ventilators. So to think that we will get robotics and VR and hydrotherapy is just we need to look into it. Seriously, I think we should just ignore that kind of evidence. That's what I also think.
And also, it might be the right time to point out also in terms of the advanced treatment. The term advanced, it makes a lot of sense when it comes to technology. In the field of engineering and technology, when you say advanced, from a current use, they are going to a better use in terms of output, what it produces. But here in medicine or anywhere, advanced doesn't mean technology, right? Because we have also often associated advancement with technology. We sort of misunderstand that any technological use is an advancement.
Right.
So whether it is technology or non-technology, the criteria for a better uh, treatment or better technology, anything is same, that it is better than previously what we are having, and it is feasible. Feasibility may change as the time goes. Some may become more accessible and available, but for a current use, it has to be effective first, and second is feasible in terms of cost and in terms of many other factors.
Yeah. Uh, Taufik, we are not going to give a lot of information about each and every therapy, because that is not the idea here. But basically, hippotherapy is horse riding. You just need
But
to.
if they had hippotherapy in that review, then
It
we
is
might
there.
be able to answer from that, because that's what I've asked also for them to put.
Uh, but anyway, I'll just tell you what the basic idea is: to just ride a horse. And if you ride a horse, what happens is uh, you are in an unstable structure, and it helps you in getting some amount of stability in sitting or dynamic sitting, if you will. And also, by definition, it is fun. It is definitely fun for a lot of children. And one of the important parameters you want to remember when you are having or when you are focusing on treatment for children is fun. It should be fun. Otherwise, I see a lot of children crying all the time. That is not what should happen. We know that learning does not happen when if you're crying, right? So it is vital that you have fun. So fun is the most important thing in hippotherapy, if at all, right?
And also even though we've asked for evidence and so on, I want to emphasize one aspect that at this point of time, we expect you to read systematic review and come to your own conclusion. And
Right.
if you then you give your conclusion that we could discuss, because we have to move forward, that you do not depend on us to say that a treatment is effective or not. Because see, what Ariom sir thinks about the treatment is that's more than that. You should be knowing what conclusion that you have come to
Correct.
based upon a evidence given. Then you can have a discussion that you have your own interpretation of the evidence, and then that can be discussed. We need to be going to that stage rather than our
The
views
YouTube
that
video.
is different,
Mm.
but you give your view based upon the evidence that you have read. Then we can discuss what we think about it. That might be our next stage if we can move forward.
Correct. So anybody wants to uh, start going?
There is a question on lifting and carrying. Does it have interventions of lifting and carrying, and does it improve outcome? In that review, did they look into lifting and carrying in related interventions?
I didn't get into the specifics of it, but again, I'll try to share the screen, and I think we should look into. Mm, um, just a minute. I just have some trouble with this. Uh,
I don't think they have that. I just did a quick search. I don't
Oh,
think they have evaluated that intervention. The
right.
possible reasons could be that there may not be any randomized control trial that focus specifically on that intervention.
That is true. Also, if at all, if there is something in it, you need to go and look into this uh, this systematic review. This is already uh, in the original uh, review which we have shared with you, right? So this review is called as task-specific gross motor training in ambulant school-age children with cerebral palsy, right? So this review, they have taken it into the state of uh, the Novak study, and they have put it in green. That is, you need to try to do it. So you need to go and see what are the intervention they gave in the RCTs which they have taken. They have taken RCTs. There are a lot of RCTs they have taken. So you need to go and look into these RCTs, right? These RCTs, and see what is the intervention they have given in those things, and try to find out, right? Rather than asking us, this is one way I would suggest you do go into it. Am I clear, Bala?
okay, sir. Thank you, sir. I will go through it, sir.
Because
My
I'm not, sorry. Go ahead.
doubt is, sir, is there any particular intervention at a different development stages? I'm
Correct.
asking
It is
for.
not about developmental stages. It is about, as you know, the level of GMFC classification.
Okay, sir.
Right. Say, for
Because
example, in this study, mostly they have taken GMC 1 to 3 because those are more chances of going to school, as you know. And
okay,
they have taken children from 4 to 8. I have already written this by seeing in it. So if the children are from 1 to 3, probably you can try this out. You can't have it as the level of the developmental level. That is not how you classify cerebral palsy, as you know very, very well.
Okay. Okay, sir.
Right?
Thank you, sir. Thank you, sir. Thank you, sir.
Morning, sir.
So this is what I would suggest you do if you are thinking that I want to give gross motor training for my child. Go to the original study they have done and find out what is their inclusion criteria, and then what is the intervention they have given, and that would give you a far better idea of how to put this into action. Prakash, you want to add more to it?
Not to the specific question, but I again want to re-emphasize our participants who are attending all this discussion is that you all will have to go to the next step. Without that, there is no learning. Because I can speak for Ariom sir also. We do not want to become another gurus. There are already
Definitely.
lots. Yes, there are already enough gurus out there. So the purpose of this meeting is for you all to become self-reliant, and you become critical. We're teaching methods how you can read and how you can evaluate and so on. So we all, it may be difficult for you to start up with, but we got to take with some baby steps, and then we can, because there is no point in us saying it's not effective. Then we are just another guru saying that one is better than the another, even though we don't give our personal opinion on it. But that's not the whole focus of this. I expect all participants to go to the next level. If you're having a question, just formulate it into a pico format, and then look for in a systematic review, did they address it? Because that process of reading and then looking into the data and then coming to a conclusion, that process is more important. When you're just asking a question and we are giving an answer, you lose all the advantage of that process. That is what going to help our thinking and so on. So we got to move to that step.
So in that vein, I would start with Arjun's question. The review mentions that importance of motivation and participation in patients and parents. How do I assess this clinically and modify it? Prakash, do you want to take this?
Take it.
Yeah. So there are methods to assess motivation in adults. In children, it is I'm not very sure of that. Uh, and one thing I would suggest in this is you see who is giving this motivational therapy, if you will. And most of the time, it might be a clinical psychologist or a social psychologist, somebody like that. So I would suggest you need those people, especially to assess these kind of complicated things, especially in parents with special children. Very difficult to do this. We used to have those things when I went to school, when I went to college. I think Selva will also remember. We used to have they used to have a course called as MSc rehabilitation in one of the colleges there. So the girls could come from there and do a lot of assessment. And there was this boy who came to do internship here, and he used to have group sessions for parents, how to cope with all the issues and things like that, how to motivate and things like that. So even though I don't have personal experience in doing those things, but I also think that there should be a teamwork with a psychologist or a sociologist. And believe me, they need they have a lot of psychological issues. They need to be looked into it. We also did a study to show that the parents are more stressed if they have children with special children. So it is needed. And for that, the basic answer is have a psychologist in your team. Right?
Good morning, sir.
Good morning. Go ahead.
Sir, Mohan Premkumar, sir.
Sure.
Sir, if a child comes with CD mixed with autism,
No, 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 no. If it is not inside the review, we are not talking about that.
okay.
Sir, I'm taking this question on sensory integration therapy. Though they're asking what is your take, but we will discuss what does the evidence suggest in terms of sensory integration. Right.
Right.
Uh, just a moment, I need to reclaim my post. Okay. Yes. Okay. So we are going to see what the evidence suggests in terms
You
of.
want to share the screen?
Yeah.
The
See now.
yeah.
Can you see now this?
No, it's not clear. Yeah.
Oh,
I
just
just went out. Yeah.
starting again. Can you
Yeah.
see now?
Yeah.
Okay. So
Can
if
you
you
just
look,
scroll it slightly? Okay. You have to scroll it down so that we can get. Yeah.
So if you look at, I'll just give the overall what what they're trying to do. This is to make it simple. Again, this is simple to read for especially for clinicians and those who have limited understanding on evidence. So they have categorized all the evidence based upon the quality of evidence and effectiveness, right? So remember, if you recall what we have discussed in how to read a systematic review, we have said that we need to look at the body of evidence and the effect size in context of the quality of evidence. So I just want to show how they have come to this conclusion and so on. You can see the grades of evidence here from high to very low, right? So they are categorized any evidence that is based upon high quality and moderate quality evidence. They recommend it as green, and any evidence that is having low and very low, that is they have put it as weak, that is yellow. And if you are having both weak evidence both for favorable and not favorable evidence, then they are finally you have an unfavorable evidence that is high quality evidence that is unfavorable, that is effectiveness suggesting that it's not working, that is put as red. That is, we have clear cut evidence with high quality that these evidences has to be, I mean these interventions has to be stopped because we have clear evidence that it's not working. So
Sorry,
anywhere
sorry,
red
sorry,
is there.
can you go again about the unfavorable, because you are not very clear. So
Okay.
just go again about the unfavorable.
Right. So they have divided evidence in terms of favorable and unfavorable. That is favorable to a particular intervention and favorable to a unfavorable to a particular intervention. So if you have high quality evidence, high and moderate quality evidence suggesting it's favorable, then they're given green. But if you
At the same time, when they will do because high is in both the
yeah.
So in the lower spectrum.
Yeah.
Yeah.
So if you have a similarly high quality and moderate quality evidence, but it suggests unfavorable, then they're given red. So
Red.
anything in between goes yellow. So whenever they show red, it means that evidence is clear. Remember, often we have a common criticism against systematic reviews. It is not giving clear-cut conclusion or decision. But this grades of evidence does give clear-cut evidence whenever they say green and red, right? So keeping that in mind, if you go to this, then you can see that there are some interventions that are for a particular interventions that are in green, lots of intervention in orange or yellow, and there are some evidence that is on S, that is red. So if you look at clearly here,
Sorry, the first one, can you just scroll up? These are for impairments or body function measures. The first part of your green light, right?
Yeah, I just want to recall what we have discussed in reading systematic review, that you need to look for a particular outcome, effectiveness, and for an outcome. Now, this particular graph suggests for impairment, that is spasticity, contracture, and muscle strength. So if you look at what is the better treatment, do we have a good treatment for managing spasticity? It is saying current evidence is for Botox, diazepam, and SDR, that is selective dorsal rhizotomy. And for contracture management, some extent casting, lower limb casting seems to provide good, relatively better strategy for contracture management. For muscle strength, we do not really have a clear-cut one. And as you can see, NDT, whether contracture management improves, NDT improves contracture management, the answer is no. So if you look at improved motor activities, that's
Sorry,
why.
1 minute, Prakash. I just want to add one more thing. The size of the bubble also has a meaning. That is, the larger the circle, it has a meaning. Probably the larger the circle, it means that there were relatively more number of studies also, right?
Yes, yes,
Yeah.
and the effect size also. I'm not
Right.
very sure, but if it's likely to correspond to effect size.
Mostly it's about
Number of studies.
yeah.
All right. So the question is on sensory integration. So again, the question has to be clearly formulated rather than asking effectiveness of sensory integration. We need to ask effectiveness of sensory integration for
To
a
do what,
particular
right?
outcome.
Right.
So if you're asking a question, does sensory integration improve motor activities? So this answers that. You can see large number of green bubbles or the green circles. What is the better treatment to improve motor activities? You have goal-directed training, you have CMT, context-focused therapy, and OT, occupational therapy, post-Botox, and bimanual training and home programs. And hippotherapy, we were discussing before, it doesn't really, the evidence is unclear. But if you look at SI, the sensory integration, what you asked for, the evidence is very clear that the sensory integration does not improve, and the red means don't do it. Red means
It does not always mean that it does not improve. It means that it might also be harmful in the sense that it might be better to do the conventional therapy than this treatment.
right. So the question to that answer to that question, it is very clear, and if it's not even in orange, it is clearly showing that we have sufficient number of studies that discourage use of sensory integration.
I will not say sufficient number, but there are okay numbers, if we will, because there are a lot of problems in doing good studies in all these things. Not necessarily technical issues, just political issues, if you will. So do anybody wants to add to what we have discussed now? Sheikh, you want to say what you have said then by talking about it? Because it seems to be a lag.
So the included studies in the updated review article, systematic review, is that 60% of the articles have been focused on the body structure and functions they had mentioned, and activities limitations, it was around only, I think, 15 to 20 was there. Then in spite of that, we can say that with respect to motor function, all the green light interventions seems to be almost everything seems to be active form of treatment. And I think except hippotherapy for that matter, even that is there for balance and symmetry. So can we infer from this is like most of the interventions which is active is always superior, and it is in spite of 60% of the included articles which targets more on body structure and function, it is more towards the passive forms are been not effective. Can we, because our conventionally we have been trained to use most of the passive treatments, can we denote, can we infer in such a way? Is it the right way to infer that?
Before that, give the clarification that is given by Naveen. That is the large circle, it denotes more than 15 RCTs. Basically, more number of studies exist.
Yeah, that's what I think that's the right way to interpret it also. Thank you, Naveen. What you are alluding to, Sheikh, is that is basically sort of, we have to extrapolate from this. It's not the function of the SR to do that, but if you try to extrapolate, it looks like that, right? Most of the things which are in green are more focused on making the child do rather than what we can do. So we can extrapolate like that, but that's not the exact function of, or that's not what the systematic review is directly telling, right? But that's no harm in doing that. In terms of yellow light, green light intervention, how to try it before switching on to another therapy if not positive outcomes are not seen. Uh, uh, the green light means that you need to try it harder. I'm not sure how we are going to shift from that. There may be difficulties in our knowledge base to implement, especially the context-based therapy or goal-directed movements. We need a lot of intuitive learning from ourselves and also from our patients and parents and things like that. We need a whole lot of dialogue between all of us to get a good treatment. But in terms of LO, what the article suggests is you need to talk again, make a decision with your, along with your co-workers or your group members, or with your parents or the child, and then make a decision. Say, for example, you try hippotherapy for 6 weeks and you have spent probably 10,000 rupees, or you have tried hydrotherapy and you have spent 10,000, 20,000, and still you have not got big changes. Then you can start having a conversation with your the child and the mother. Okay, shall we try something else because it doesn't seem to be working, right? So that is the basic part of your amber light. It says that it's not that you just need to throw it away. You need to introspect your treatment as well as talk with your patient and the guardians and the caregivers.
I also want to, I'll, from a different take, if I have to see from a clinician's, right? How I see it is the conventional treatment should, the green intervention, what is added as a green light, the conventional treatment should be comprising of primarily green whenever green is available.
Right.
It is very important that if you are giving a treatment for an outcome for which an intervention in the green is available, now that is the bigger issue. I would say it's unethical to offer a treatment which is known ineffective with the availability of something that is already effective. That's something that we already know, right? So if you look at your practice and see how many red interventions that you are having, right, and your proportion of conventional treatment, then you might have to, previously if you doing it without the knowledge, I don't know if that's acceptable, but still you will have to think, one will have to think how you are going to change your conventional practice that primarily consists of, whenever green is not available, we can look for any other intervention. But the problem comes when you choose an intervention that is either green or red, either yellow or red, when we already have a green intervention for that outcome.
Yeah, I think that's a fair point. And also one of the issues I see is that a lot of people offer hydrotherapy because they learned hydrotherapy. So that's another point I would add to what Prakash was saying. That is, you don't offer something because you have learned it. Offer something to patients because it is having some amount of evidence and it seems to be working better than the next one. I'm not saying this is the best, but better than the next one, right? So try to use those things, right? So
Gayatri raised hand.
Okay.
Gayatri, are you there? Gayatri KC, would you like to ask a question? Okay, we'll move ahead then.
Okay. combining 2 or 3 interventions, is it good? Again, not necessarily. Say, for example, if you combine 3 or 4 therapy in the amber region, does not make it better. So I'm not sure how that works. But at the same time, say, for example, if you are using, you're having a surgery, right? A multi-level surgery, single event multi-level surgery. But the surgery is in orange, but post-operatively or in combination with the surgery, what treatment you are going to offer should be from the green region. That is, it should be context-specific treatment or goal-directed treatment or something like that, rather than just making them stand on a vibrator or on a hippotherapy or something like that. Adding more orange does not make it better. The common example I tell is, if you take garbage from every people's home and put it in a big basket, still it is garbage. It is still not food, or it is of no value to anybody, right? So you can't pick all the poorly valuable therapy and think that that will make sense.
The logic behind asking that kind of question is that, so if you have a two treatment which is of low or less effect size, and you add two less and less, then it becomes slightly medium. That is the logic behind asking that question. But the logic obviously sounds it cannot be like that. We are talking about it's not like 1 plus 1 will become 2, or 1 plus 1 will become 3. It's not about that. An ineffective treatment will remain ineffective. It cannot be added that way.
The Gayatri wants to ask. She didn't hear it, so
I
if
think
she wants
she left. I think she's having some sort of network issues. If she comes back, we will get to her.
Sairam asks, entity is very broad. Who said it is very broad? It is just a active assisted treatment for normalizing tone and posture and whatnot. Sure, they keep on telling all sorts of nonsensical words. What broad? Physiotherapy itself is very small. It's the active movement. What else is there? So talking about words like this does not make it any better. Why is it NDT and SI? Sorry, Prakash, I'll just finish my point.
Okay.
So the basic idea of NDT and SI, why it's not working is, remember, the child explores and learns. I'm not talking about cerebral palsy child or this child or that child. Any child. If you are a father, you will know that the child explores and learns. And if you are always holding the child and putting him on a JCP machine or on the ceiling or on some nonsensical thing, or if you are always holding the child, how is he going to learn? That is why our schools make us dumber, because they don't allow you to explore, right? That is one of the reasons why NDT and SI does not work. And the other thing I think why it is not working is because when this was started by, I unlike SI, I think when Bobat started, she had a clear idea. She came from a theoretical point of view, which was old. It was written in 50s, right? As time goes by, it became old, right? Like everything in medicine, it became old. They should have thrown it away. But because it is very lucrative, right? It is anywhere from 1 lakh to 4 lakhs to get this course. They are not doing it. And also remember, they are charging you 4 lakhs, 2 lakhs to 4 lakhs, but they have not done one study, not even just a one study. That is the point. It is a money grabbing mission. It is not for the betterment of the children. It is for the betterment of the people who teach it. Good.
If NDT is very broad, and physiotherapy can be said very broad, and whole medicine can be said very broad, right? So if you're using this kind of vague term to say something broad, there are other interventions can also be very broad, except that one has to learn other interventions also to know how broad other thing is. And the second thing is fixed protocol. That protocol varies from person to person and all these things. It can vary. What exactly varies is the question. Whatever variation is are there, all variations can be tested. All medical interventions are also very unlike what we think. It doesn't vary. There are variations in the way it's been prescribed, but that should not affect the effectiveness of treatment, right? So this is the age old definition saying NDT is broad, SA is so broad, and so on. Everything task oriented therapy is also very, very broad. Or if I'm allowed to, I will add 5 very broad into it, but that doesn't make it untestable, right? So yeah, that's all what I wanted to say.
Okay. Uh, they have asked, is rhizotomy useful? As you can imagine, as we have been keeping on saying, you can't ask whether it is useful. We want to ask whether it is useful for what? What can it make better? Useful is not a term, right? It needs a sort of an action word. If it needs another word, it is useful to make your teeth brighter if you eat a chewing gum, something like that, right? So you need to have to ask yourself, is it effective in reducing this or improving that and things like that. Now, Prakash, can you make me the host or so that I can share?
This time. Yeah.
Uh, Now, if you see in this, it says that it has green, but you need to remember it is for changing the tone. It is not saying that if you do diazepam or selective dorsectomy or something like that, it will make them walk or run or do things like that. What it tells you is that they will have a change in tone. That is all. That is what we are saying from the last uh, few meetings, that don't see it as effective or not effective. See effective in doing what, that is important. And as you can see, this is just for changing the tone, nothing more, nothing less. Am I clear? Okay. So what next? Anybody else has more questions?
Sir, here, Selva.
Go ahead, Selva. Go ahead, Selva. I think we got cut off.
Yeah. Hello.
Selva, yeah, can you repeat it, because we got cut off?
Okay, so I just wanted to know, is it a time to, once we realize that active treatment is going to work in cerebral palsy, so is it a time to
Right.
even go further nuances? For example, when we are implementing CAMT, in the practical point of view, it's quite difficulty expressed by the
Difficult.
parents,
Right.
the children, and there are a lot of interventional issues, like when we are practically
Correct.
applying it. So can we start
Correct.
moving towards standardizing things on how to implement this active methods of treatment in children, especially in children?
Correct. Go ahead.
So
That's it?
yeah, so it's not only that, even when we are giving a home program, so the interventions becoming very, very wide. Like we need to even educate the parents in such a way that they really get it. and most of them just really not believing it that they can actually understand this kind of thing, and then they can implement it. Actually, they can only even offer a treatment, even though it is very much effective. So how are we going to address such issues?
Right.
We are going to implement this thing.
Salwa, I think again you got cut off, but anyway, I think that's the point. I think uh, now I'll just again share the one part of it before going into the next part of it. Now, if you see in the intervention, already somebody was talking about these parts, right? The how to coach patient education. There are a lot of things are happening here, right? What we call as patient outcomes, right? This is sort of just starting now. We are teaching more how to motivate them, how to cope uh, with the child who is disabled and things like that. They are just starting it. So I think I completely understand that we need to. It is difficult for us to make them do a lot of things and make them understand they are more important than us as therapist or treatment therapist or whatever it is, right? So that is the first point I want to talk. I want to say. The next thing is about KT, that is changing our practice, right? Uh, One of the reasons we have a lot of difficulty in this is uh, this is very common. Whenever I say this is not working, people shout at me. They say that I'm sort of crazy or I know everything or things like that.
No, you don't know.
Right, that is the point. I'm saying I don't know this is working, right? I'm saying there might be a better option. And people start shouting at us. So there seems to be a socio-political issue rather than just a medical issue. The next point is there is a huge financial consideration. Say, for example, if you have learned hydrotherapy, and I'm assuming the course is anywhere from 5,000 to 20,000. If it is online hydrotherapy, probably we can learn it for 50 rupees. But anyway, if you have learned that, and if I come and tell you that there is a better option than hydrotherapy, you are not going to listen to it. That is the problem. But I just want to share only one thing about KT, right? So this is a study which was done in 2013. Um, so what they have done is, like here we have Sishu Abhiman Thitam or something like that. They have a lot of physiotherapists who go and treat children with disability, right? Even in Tamil Nadu, they do that. So they have this group of 100 people who treat people with cerebral palsy and other disabilities. So what they have done is they first brought all the 100 people and they gave a training. So they had 5-day training of EVM. Then every 10 people were given a mentor, if you will, right? So what it means is the 10 people, if they have any doubt, they will ask the mentor. So whenever, as you said, if somebody comes and tells, no, this is very difficult for me to apply, right? This active therapy is difficult to apply. You told us to apply. So what they will do is they will have a meeting between all 10 and the mentor will try to help them to achieve it, right? Because other 9 people also can say that, no, I did like this. This is a better way to do it or something like that. So they did this KT and they have shown good results. And that got out of 10 prizes. I think she got 8th or 9th like that when I went to a conference. And it was one of the um, better papers I have seen in that also. So that kind of thing has to happen here. That I completely agree. I keep on telling to Prakash also, I don't want to do research. I just want to do KT. That is, I want people to change for the already existing things. We cannot just go on putting more research finding and nobody is using it, right? So we need to change. We need to change. There are two solutions. One is the carrot, another one is the stick. And I don't have the carrot or I don't have the stick. So I don't know how to change. So if anybody else has solutions, I'll be more than happy to look into it.
No, it's not about research versus KT. KT is
No,
not.
I'm just saying.
I'm just for clarification that
yeah.
I'm saying
Yeah.
is that one is where implementation is also a critical part of evidence or science, because you can't really have so much of knowledge available not implemented. And also to expect that availability of knowledge will automatically translate in in practice is some sort of dream that we were all living in at some time. But yeah. Right. Next, there is one question, which previous question itself from Nidhi Kala, that there is so much focus on gait training, but is it really possible to change the gait per se, especially with the use of treadmill as they considered it and part of functional ability training?
Again, I want you to re-emphasize what Prakash has told already. Find out what they mean by what improved. My understood? They are not saying gait is improved. They are saying one parameter of the gait is improved. That is, most of the studies I have looked into, they have said the speed of the gait is getting better. My understood? That is one of the important parameters which
And
improves.
also that I think she is asking changes in gait in every patient is possible.
That's not how it works, right?
Yeah, that's where I think you need to look at evidence. Evidence is not generalizable to a whole population. If you look at most of the treadmill training studies, the participants are usually GMFCS level 3, 2, and 1.
Yeah.
Right. So you have this evidence is generalizable to children who are having GMFCS level 2 and 1, not for 4 and 5. So if you're asking, can gait improve for 4 and 5? Obviously, we don't have any evidence, and also we know that its chances are very, very less as far as walking is concerned, right? So you need to look at it is evidence is applicable to a particular population which they have studied, not for all patients.
Correct. That's where your inclusion and exclusion of your systematic review or the individual as it is, you need to look into it. And we know in cerebral palsy, most of the evidence is for 1 to 3 in terms of changing gait and things like that. Right. So you just have to keep that in mind. And even if you have all children with, even if you have children with 1, 2, 3, or then also that it may not be applicable because there may be other factors which are hindering. Say, for example, the child may come from a poor background where they don't have space to walk in their home. So there are other factors also look into it, which may mitigate your intervention also or influence your intervention also. You need to be wary of that.
I want you to take question from Mr. Arjun.
What does it say? Parental intervention. That's what I was saying about. There are a lot of studies which are happening now. Only parental evidence interventions are getting. Now only it's getting better because we all get frustrated when they don't understand it properly or I can't tell them properly, and they all want the child to become normal. And also, one of the things which are frustrating is the neurologists also don't give them a complete picture or any picture. They just tell them, go to the physiotherapy, as though we have a magic wand to say, G Boomba, everything goes away, right? And that's not how it works. So, and also remember, we are telling them bad news. We are not giving them, in a way, good news, if at all, right? So those things are needs a lot of diplomatic way of putting it. At the same time, you can't give them false hope also, right? So you need to be in the middle path, and that needs, I think, we need special training, and we need good psychologists in our team. But sadly, we are not getting that. But I'm hoping we will get that slowly there, because I think that is one thing which is vital. You can have just a OT or a PT, it doesn't matter, we all get the same. But we need a psychologist or a socio-psychologist who can help in putting in school, to putting them in play group, all sorts of things for socialization of children with disabilities, vital. How to fight for sports and things like that, that's also vital. So this expanding field, especially in India, it is very poorly understood. I'm hoping that if you are doing any project or if you are doing any studies, I will hope you can do in these things rather than just talking about stretching or spasticity reduction, all other nonsense.
This is actually a very real problem that you face
Correct.
in clinical setup, right? So what I would suggest that if you're a clinician, first, that it is good that you need to first recognize this as a problem. That as a physiotherapist, especially if you're dealing with children with disability, many times we are in a position to give bad news, and unfortunately, some clinicians, because of the difficulties that is there in giving the bad news, that they adopt a strategy in which they somewhat give false hope, even though that is not what their intention is, because it's very complicated situation to tell a young mother or a young parents to that your child may not walk for the rest of the life, or your child may have to be dependent on many other things. Very difficult and complicated issue, right? So because of the lack of skills and understanding, sometimes therapists were in a position there where give false hope. They will say that if you take good treatment for a long time, you will get better, and so on. So what I would suggest is, if you are a clinician, and ideally if you have access to psychologists to talk about it, is good, but we know in clinical practice it's not always the case. So I suggest clinicians working with children with cerebral palsy have to have some fundamental training on how you give a bad news, right? Say for in our university, we have actually introduced a course called patient education and communication, where we one part of it is where we talk about giving what are different strategies for giving bad news. So that's if you are an educator, you must be thinking how you will include this. But if you're a clinician, what you could do, I would suggest that find a good clinical psychologist or a psychiatrist, meet with them, take an appointment from them, and ask for their help, right? How I can deliver, get something. If, and I'm not saying that would you will learn everything, but you have to start seeking help. You will find many clinicians, that psychologists or psychiatrists would be willing to help. Or if you take 4 or 5 people, at least one of them will be willing to help you give a crash course on it. So don't think that there is no courses are available. What do I do? If you approach such clinicians, some of them will be very much willing to teach.
Okay. And if you are in Chennai, I know you're a good psychologist, so you can just hit me. I can, I can get to her, and you can sort of learn about that also. And also, I know a place where they teach psychology courses like CBT and adherence therapy, all sorts of treatment in a short course, not necessarily physiotherapy focused, but you can sort of go through it. They do it in Chennai. I don't know in other places.
So next,
Okay,
Devanshi Doshi.
right. High evidence for task specific training, how to exactly target in children. Now, again, if you want to, if you go through the article, you will see that this is where we keep on saying that you need to understand what is the. You can see that they were all age 4 to 18, right? They were slightly older adults. I mean, slightly older children. Sorry, adults. So it is slightly easier than in very small children. And as you have correctly pointed out, most of it should be play-based. That's what we mean by activity-based in older adults, right? So there should be some sort of play involved, or that's what they mean by goal directed or context specific treatment, right? So that kind of things is far more suitable. I'll just give you a simple example what they have done in what we call as context specific therapy. Now the child is not able to hold like this, right? He can do this movement to certain extent, some movement like this, but he cannot grasp the food. So what the study researchers did was they had a bag of Cheetos. You all remember Cheetos, right? 40 days, 50 days has happened. So we have forget Cheetos. And my son and I am dreaming about Cheetos, right? So what they did was they put butter or sort of sticky surface on the child's hand. And when the child put the hand inside the bag, the Cheetos stuck to the hand. The child did not take it as such, right? And then sort of they started eating like this, right? That is what they did for eating as such. This you can do even for a 2-year-old or a 3-year-old or a 4-year-old, not necessarily Cheetos, but I'm just saying that because eating is a sort of a intuitive task, if you will.
You
So
can add a game element to that also, just to
correct.
keep them focused.
So there are many ways a lot of people are trying out. That's what I keep on saying, that you need to be intuitive and you need to put yourself in the child's shoe so that you can understand how the child will actively participate in what you're doing, right? If it is crying, just leave it, go to the next. Don't keep on pushing them. Children are not like adults. You can't keep on pushing them. So have a lot of varied ideas. Ask your one day, I think Prakash will remember, we went to Hyderabad, and one of the father brought the child where we were staying. And the first thing I asked is, what is the child very happy? When is your child very happy? And he said that when he's playing with water. I said, then make your child stand and keep a tray of water in the table and just ask her to play, right? And she will be doing this, and you can make her stand, right? So you need to be ingenious, if you will, to have activities which are happy for your child, if you will, or which is uh, which the child may adhere more to. Prakash, you want to add more?
There are a few things which I commonly observed, especially from young clinicians who are entering into pediatrics. Generally, I would say to all my students that uh, you have to ask yourself how good you are with children. It's not about your knowledge about cerebral palsy will help. If you're not good with your children, good with children, it's very difficult to manage. So, as an extension of it, what I say that to look at the world from children's perspective, it's very difficult for many adults. Say we think that we give an intervention with an aim of making them walk, and they don't walk. We get irritated at times because our goal is walking, children's goal may not be walking. They have their way they look at the world is
Right.
very different. I see many times people get frustrated, or they keep telling them no, keep straight, keep it straight, don't bend, and so on. And children just become inattentive, they get angry. And so maybe many senior clinicians would understand these things better. But if you're a young clinician managing children, you have to understand that many fundamental principles or many strategies that we use in adults are often of very limited use, because adults have a clear motivation, most of them, about what is the goal they want to achieve and so on. So their participation is different. Children, they have a different motivation, right? They may not even realize, at least if they're very young, that they are disabled, they are different from others, and so on. It will take some time for them to grasp, right? So you needed to keep that in mind when we are developing. That's why the play and other thing comes second. I wanted to say that we need to discuss the task specificity, context specificity principles with parents. We think that they don't understand, but we got to tell them, because many times parents doesn't get. So if you say that I'm looking for some intervention which he actively does something related, then you will see parents will come up with lots of different ideas, because parents knows their children very well. We spend 1 hour time, but if you tell them this is what I'm trying to do, then the parents are likely to come up with lots of different ideas of how we can do it context specific. So as clinician, we need to have some sort of lot of sharing with goals, our principles of treatment, why we think this needs to be done, and so on. And of course, some parents doesn't agree. Right? That doesn't mean we shouldn't try doing it. If they doesn't agree, we have to change the strategy.
And also, I want to again redirect to what Bala has done. Bala Chandar from Trichy. A lot of people might have known about what he wrote in the blog which Prakash published, part of neuro. What's it called? Sorry?
Physiotherapy update.
Ah, so you can see that the children were, he keeps on telling us that the children were happy. They were not thinking that I'm not standing straight as Tendulkar or something like that. They were happy to hit the ball or play as a group or win and things like that. So it is vital if we can have something uh, like what Bala is doing, where uh, game is a focus, group is a focus. All these things are vital for the children to blossom into their, or get their utmost potential they can get into. So I think that is vital. And again, I think we need to follow what he has done. And he also wants to tell us that is the therapy really working more than the natural recovery enriched in the environment? Um, as you can imagine, it will. That's why they have a lot of green. But it is not like more therapy is far better. Uh, in the children, you need to sort of have more and more lot of discovery learning, which they, for that enrich environment is it's a wonderful idea, but we have not still completely understood, and we have not completely understood how to give it. All these things are still in the works, so it will take some time, Bala.
And also here there is again a lot of misunderstanding about the recovery trajectory of children with cerebral palsy. Recovery trajectory doesn't follow something of going back, reaching the normal development and reaching there. Now, this is normal development. Recovery trajectory is not our idea is go and reach there. This will go on different way, right? So we have to understand what we mean by recovery in children with cerebral palsy. From their existing state, they are trying to get better, and we should not have normal development as a reference standard. That's a common mistake, and parents
Correct.
also look at that way. But it is our, because we are professionals, it is our duty to constantly try and explain to them that we are not trying to reach what children without cerebral palsy could achieve. That cannot be a goal, because children, if you get cerebral palsy, and you get cerebral palsy for life, right? So there is no point of trying to get, it's a different uh, you have to look at, learn to, or educate parents to turn to accept their children as they are, and from their current state, how they can live a better life within their limited capacity or whatever they have. How you can change environment, how you can change our people's views in order to educate them. These all should be an important goal. Say for example, the child cannot walk. Rather than constantly thinking of walking, we need to think by walking what they want to achieve. They want to
Right.
participate in sports, and they want to go and meet people, they want to go to school. If it is not possible by walking, what are the other means by which they can experience this? So if you're looking that way, then I think the overall treatment focus would eventually come to this stage.
Um,
And
okay.
there's a question from Arjun, you might want to take that. How do you explain the ineffective treatment or something?
I'll just first I'll tell you. Uh, Yeah, it is very, very, very difficult to make convince somebody that uh, whatever they are doing is wrong, or we need to change. As you can see from thousands of people who are following me. Like, nobody wants to hear that. And also, for people who have an understanding of what we call as the dynamic theory basically says that there is a stable state and then there is an unstable state, and most of our brain is in a stable state and it doesn't want to move from that state. It is difficult to move the brain from one state to another. It's not that easy, right? So it's fairly difficult, right? I have told a lot of parents that they have to make the child walk, but when I say that, there are another 50 physiotherapists who are saying that if you walk now, you will always walk in an abnormal posture or abnormal pattern, so you have to wait. Um, I'm not talking just about physiotherapy. I'm talking about all sorts of therapy. So it's difficult. But what I would, this is my feeling is that you need to keep on educating your patients. That is vital. And especially if you think that this is money grabbing or this is unethical, you need to work hard and keep on trying. In different methods, you need to make them understand. One of the methods which I think is slightly better is show other people or other children who are getting better. This is what my when we went to college, um, I went to medical college in Tanjavur. Tanjavur now will look like an overgrown village. In the 90s, it was really an overgrown village. And we had a cardiothoracic department. And rheumatic fever was sort of endemic to that particular region. And they have a lot of, they will get a lot of patients there. And when the surgeon said that you need a surgery, the patients will just run away from that because cardiac surgery was they were so afraid of cardiac surgery. Now, so what they used to do is they will bring people who have had surgery, right? And tell them that, see, these people have undergone surgery, they have got better, so don't be afraid. So that kind of principles also helps. If you have people or if you have other children who are slightly better or who are doing better in school or walking or something like that, show them that's a wonderful idea. Also, Prakash will remember we had a patient when he went to school, went to college. That was in 2002 to 2000, 2002, 2003, I think. So we had a child there. Now she is finished college and she's an engineer, right? Now, what I want, we are trying this for quite some time. It's not happening, but we will do it probably in one of the conference which we will try to arrange. We want these people to come and talk to physiotherapists as well as to patients. That is their journey of how they went from that to finishing college, staying in a hostel. She stayed in a hostel and finished. She still walks with what we call as a diplegic gait. Don't get me wrong. She's in a crouch position. She will walk with rather awkwardly, if you would. But she has done that. So we want that also. If we can, if that kind of things happen, then I think it will be a. These are the methods I think we can use. Um, that's all.
I just want to add that, say, for example, if you are explaining something and patients are not willing to accept, now that cannot be a reason for us not to tell. It is our ethical responsibility to tell that you think from your professional point of view, this treatment is not effective, and if they're meant to be a money grabbing exercise, you are bound to give your professional opinion. To take it or not, it is up to the parents. Just because they are not taking it, we should not stop saying it. It's our response. We got to say that to everyone.
Yeah. Tawfiq, that's a good idea. We're having a lot of music and dance and having sort of a rather than a sterile environment. A lot of people think that they have to wear a coat when they go to a clinic. Especially, they think that it's a bad idea to do that in a pediatric clinic, whether it is just a pediatric OPD or special clinic. So one of the things which will make it far more informal, not intervention kind of environment, song and dance makes a wonderful addition, if you will, right?
I want to add a caveat to use of songs and dance,
Right.
because I am saying this is repeatedly done, not just for children with cerebral palsy, for any children. Nowadays, they often give them a cell phone with some music that is coming just to keep them engaged. Now, there has to be a limit to with which you are doing. If the child is all the time engaged with listening to something in it, then their cognitive development and other development can have a impact on it. They need to be involved something active and so on. So if so, we just have to see whether the purpose is to keep them focused or just uh, keep them silent.
Yep. A lot of screen addiction, I suppose. Okay. Um, so, any other questions? I'll just want to, if you don't have any questions, I'll just uh, I'll just share this this picture because as you can see, there are other things also in this review, from communication to self-care, drooling, how to make a wuro, swallowing, and that kind of things also. Why I'm talking about this is that you need to tell your patients if they ask you, okay, what can I do for this or that? Try to sort of nudge them towards which has the highest level of evidence. So they have just an understanding. Because as somebody has already pointed out, there are hundreds of sort of ineffective, not science-based treatment. So have some idea about how all these things are working, especially in the earlier review, the 13th review, there was less amount of green things. Now they have a lot of greens. You can see there are a lot of greens here. So those things you need to have it in mind and sort of use them also. And the other thing I want to talk about is this early intervention. A lot of people keep on telling me early intervention, early intervention, early intervention. And I don't know how to give early intervention, or what is the early intervention in 6-year-old, or when 6 months old or 1-year-old. I am not very sure of it. And a lot of people keep on saying that you need treatment every day for a 6-month-old or a 1-year-old. I am not very sure what it means also, and as usual you can also see that uh, the evidence is not also that much large. So why I'm saying about that is because it sort of makes the child more crankier. Sometimes it looks very, very sad to see people putting the child on a ball and doing all sorts of circus with that on a 1-year-old. Just breaks my heart. I don't know why we need to do that also. So those are the things which we need to have an understanding from the systematic review. Bala asks, what document should we have maintaining while giving intervention? Please list the scales, outcome measures. Okay, that's not the that's not the focus of this review, but one of the common things they do is the GMFC, the gross motor function measurement 66, or what is
GMFM
it
and
called?
GMFCS.
FCS 66, or what is that?
66
I think
now. 66.
something like that. That's what is used, but everything has its own limitation and own use and things like that. And you can also use just the items of just walking, just sitting and things like that. But when Robert Palestino came, he said one thing which I think is a good idea, which we try to follow, is that write a GAS for 5 or 3 GAS for each child. What are you trying to improve, right? Just 3 or 5, maximum of 5, and put it in a board, and then ask the child or the mother to move the setting from, say, for example, if they started at 0, if they go to 1, ask your mother, have we gone to 1? If she says yes, ask the child and the mother to move it to 1. That is what they are trying to say, is that the change should reflect not what you should not alone say that it has changed. Your parent and your child also has to accept that, okay, I have attained some changes. So that is a good idea if you are in a school or something like that, where the goals and goal achievement are shared. So that, I think, is a far better idea than anything I have seen in terms of documentation. Prakash?
I recommend 3 scales for if you are
Okay.
managing cerebral palsy: GMFM, GMFCS, and goal attainment scale. Because GMFM, GMFM can give you some quantitative information, and for physiotherapists, for us to see how much it's changing, and also parents might be interested in, and to communicate to others also. And GMFCS, it's a classification system that tells you,
That
what kind of
that you
intervention
can't
works.
go away from it, right? That
Yeah.
has to happen. There's no other
Yes.
alternative for that. Right.
And the goal attainment scale, list goals, smart goals, something that is realistic and achievable, and have it. These 3, it's fundamental. I would say it's a must. Every child you manage, these 3 things has to be there. Without that, it's I don't know.
Okay. Anybody else?
Thank you, sir.
Yeah, go ahead.
For the past 8 years, I have been collecting the GMFM and GMFCS and also MACS. But there is no much difference in the GMFM also, sir. Once a child attains some scoring, even after 2 years or 3 years of treatment also, there is very less amount we can see the improvement, sir. How we can make it as a assessment tool to show the improvement, even though the child is doing some activities better than before, but the scale is not showing good improvements. Maybe the child can walk better, maybe they can walk in the indoor, but there is no change in the score level, sir.
That's why I said that if you had a GAS along with that, it might have been
No, sir,
better.
in this, may I just
And also, sorry, 1 minute, I'll just finish. And also, I want to congratulate you. You have found out one of the important things in life. That is, changes are small, and that is what a physical intervention can give. Go ahead, Prakash.
Yes,
there is another way of looking at it. Say GMFM has been extensively validated for the exact purposes that you are saying. So if the GMFM doesn't show, especially for walking, if it doesn't show much change, that means that child is not achieving any significant, clinically significant improvement. So that we should be seeing that whatever we think we have achieved is not worthwhile to the patient, rather than which outcome would be better even to look at. That's not how we can do, right? If it doesn't show much, and probably there is not much as happened. This is related to gross motor functions only. If the patients have improved in some self-care activities and so on, then again GMFM does not measure changes in that.
yes, sir, exactly, sir. Some activities the child are able to do, but there is no change in the GMF score.
And also we know that for level 4 and level 5, you will not see much change in GMF. Yes. There is very little changes, especially after now 2-3 years. You will see very little change in GMF.
And also for that only, I think you need a GAS, because in those patients, it is not about changing this or that. It is about achieving certain goals, right? Which might be with lot of modifications, with lot of assistance, lot of things might have been happening. So that has to be looked at from the right prism.
And also there is misunderstanding about the value of outcome measure. Each
Yeah.
outcome measure has its purpose. It only can do certain things. It cannot do everything that we want. So we need to select outcome measure based upon the purpose that we are expecting.
So we just started to use the Canadian
Mhm.
Occupational Performance Measures, COPM,
Yes.
but it is very difficult to proceed because it also shows very little changes only, sir. The satisfaction level is not changing much.
That's what the evidence suggests also.
So the parents are not motivated and they feel that the child is not showing good improvement. They not having good opinion about the physiotherapist. They feel that the therapy is not going very well like that.
Parental education before beginning of
That's
treatment
what we were
is
talking
essential.
about.
If you
Yeah.
have started giving false
Uh,
hope and eventually, and also not necessarily a problem of therapist. Most parents also expect some drastic improvement to come and so on, but it requires a lot of time and effort from their side also to accept and understand the nature of cerebral palsy and its recovery. They need to be educated.
this is my experience I just shared, sir.
Yeah.
Thank you,
No,
sir.
no, this is what a lot of people are not understanding, that they think that they are some sort of godsend for all these children, and they think that whatever they are doing is the best in the world, and all sorts of things comes from their idea that they are not assessing or looking into themselves, right? If we look into ourselves, we know that uh, we are slowly moving. We are not sort of pushing them, and they are just running in a 100 meters dash after 10 weeks or something like that. I think that's one of the best feedbacks we got today, I suppose, or discussions.
Yeah, and also as therapists, we need to work towards pushing parents towards a functional goal rather than getting normal. You need to, okay, we will have a goal of him going to school or some form of school, even if it is not a regular school. He's getting educated, okay, at least he gets a primary education. If we need to slowly push the parents towards that kind of goal rather than independence in walking and other aspects. It's complex, but that's the whole management of cerebral palsy is complex from multiple levels. So
So this
Yeah.
1 month given a good chance for the assessment, sir. Now
Mhm.
in the home, the children are doing a lot of activities because all the family members are in the home. So they engage with the children and the children are motivated. They do all the self-care activities. They learn a lot of skills, lot of play activities. Now I could
Wonderful.
see a lot of difference, sir. I'm very happy to see the children's
So,
participation.
what does it tell you anyway?
Without our presence, they're doing better, sir.
Right, that's what family-centric therapy is, right? Because we are thinking always therapist-centric. We miss out one of the most important thing. That's what I keep on telling to all my parents who come here, because we see only 1 month, 15 days once or monthly once. That's our frequency of seeing, not like you, right? I always say that because they are all going to some other physiotherapy department. Because they have come from other places. I keep on telling them, if you miss 2 or 3 days, don't worry, because a lot of parents think that you have to come to physiotherapy every day. The physiotherapists also say that also, right? The other thing I would also suggest is the mother is the most important person. The mother is going to change the child, not the physiotherapist. That we need to teach our parents. That is what I think is most important.
shall we conclude on that note?
Yeah. So I just want to again re-emphasize that uh, the evidence is current. What it means is it might change with time. Some of it will get better. The greener things will get better as more and more studies come into focus. The orange may get into greener as more and more studies come into to RCTs come get published. Until that, as Bala has said, sort of look into yourself whether you are the godsend for all these children, or you are just one part of the folks of a larger wheel, right? And be humble and have your child get treatments which are in the greener things. As Sheikh has pointed out, the greener things, what is more in the green is active participation of the child. For the active participation, have anything from cricket to cricket playing to playing in the sand or water or things like that. So get them involved. Put them in school. Taking them to school is vital, and also changing the mindset of the parents is also vital, which Selva has pointed out, Bala has pointed out, and Arjun also has pointed out. These are the things which we are uh, very much lacking in. We need to work on this as Indian therapists, because here we have very little information about those things. So I would suggest we work on those things. And thank you for your participation. Prakash, you want to say anything?
That's all.
Okay. Thank you. Bye-bye.